me. Thank you again for attending this program offered by Cancer Support Community. Please join me in welcoming our speakers for today, Lisa Ovesen. As a former trauma nurse in an intensive care unit, Lisa was recruited to work in the hospital's oncology department for procedures. It was during this time that Lisa discovered a passion for caring for medical oncology and hematology patients. She was especially drawn to direct patient care after seeing family members and friends who battled cancer. Lisa's area of special interest include hematology, holistic therapies, and supportive care. Lisa is also a lead advanced practice provider for the OHC Supportive Care Program. In her free time, she enjoys traveling, cooking, gardening, tending her small flock of chickens, Girl Scouts, spending time with family, and the close-knit group of friends she has had for many years.
Good evening, everyone. As I think you've heard, my name is Lisa Ovesen, and I am a nurse practitioner with OHC. I am the co-lead of their supportive care program, and I'm here tonight to talk to you about palliative care. I want to thank Cancer Support Community for giving me the opportunity to come and talk with you about something that I am really passionate about. So I'll start off just by saying that I had a little difficulty initially kind of putting this presentation together because palliative care is something that I could really talk for a long time about you know, could really get into the weeds in terms of details of what we do, but I needed to sort of instead give you a high level overview about what palliative care is and how perhaps it might fit into your life. So what is palliative care? So palliative care is specialized care for people with a serious illness. It's advanced symptom management. Our focus is on improving your quality of life. We help guide the patient and their family through complex medical decision-making, and we offer psychosocial and spiritual support. So who can enroll in palliative care? The truth is anyone can enroll in palliative care. So anyone who has a serious illness and is in need of advanced symptom management is appropriate for palliative care. My particular background comes in the setting of cancer, but we see people with, you know, palliative care is appropriate for folks with dementia or chronic pain, congestive heart failure, kidney disease, liver disease. In fact, when I was training in palliative care, oncology and cancer was just a small bit of what of the patients that I learned to take care of. So palliative care is really for anyone. So palliative care is appropriate at any stage of a person's illness and is provided at the same time as the treatment, and that's really important. And I want to kind of make the point here that palliative care is not to be confused with hospice. And I think what scares people away from palliative care is they really do sort of link those words palliative and hospice together. And it sounds very scary to people. And oftentimes outpatient palliative care programs are provided by hospice providers. And that can be very confusing and scary for people. So palliative care is very different from hospice, and we'll talk about that here. So hospice care focuses on the care and comfort and quality of life of a person who has a serious illness who is approaching the end of their life. And that's the difference between palliative care and hospice. So it does all of the same things that palliative care does. They provide comfort care as well as support for the family. But in the case of hospice, any attempts to cure the person's illness are stopped. So to use cancer as an example, you know, we do not enroll in hospice services if someone is wanting to continue treatment for their cancer. And so hospice is provided for a person with a terminal illness whose doctor believes that he or she has less than 6 months to live. So sometimes people will ask me, well, what happens if someone who is under hospice care lives longer than 6 months? And the answer is that, you know, if the doctor continues to certify that that person is still close to death, Medicare will continue to pay for hospice services. The other thing is that it's also possible to sort of bump in and out of hospice care. And so sometimes, you know, hospice makes people actually better because they're getting the good quality care that they need. And so they'll bump out of hospice and then return later if the healthcare provider still believes that the person, you know, may be within 6 months to live. So some facts about hospice. So more than 1.65 million Americans utilize hospice services annually. And, you know, what's interesting is that 88% of patients tell us that they want to live and die in their home. But unfortunately, about 40% of US deaths happen in the hospital. And you might hear people say that hospice killed their family member. That's actually one of the most common things that I hear patients say to me when I start talking to them about palliative care and then hospice. They'll say, oh, hospice, you know, my mom enrolled in hospice and she died the next day. And what I would say to that is, then mom was enrolled in hospice, you know, too late. And in fact, actually, the evidence says that patients can oftentimes live longer with hospice care than they would live without it. 94% of families who rate their experience with hospice, they say that it is excellent or very good. So generally, people are usually very happy that they've had hospice on board. So who pays for these services? So outpatient palliative care is billed to your insurance company, just like a doctor's visit. When patients come to see me in the office for palliative care, or what we here at OHC called supportive care, patients pay a copay just like, you know, you would for a regular doctor's visit. It's just a provider copay. Hospice care is covered by Medicare, Medicaid, and most private insurance plans. So people have a hospice benefit, whether you know about it or not. The odds are you have a hospice benefit with your insurance, and typically patients pay no money out of pocket for hospice services. So when we think about a head-to-head of palliative care versus hospice, so palliative care cannot provide the same level and level of service and support that hospice can. It's typically on an outpatient basis, limited to 1 to 2 visits per month. It does not pay for any type of medications or equipment. Hospice, on the other hand, has a lot more team support in the home, and it offers 24/7 service and support. So if a person is enrolled in hospice and we find that they need a hospital bed, generally most hospice organizations are able to produce that hospital bed within 24 hours, if not even the same day. So they are very quick to offer all of the supplies and things like that that patients need as they are staying in their home. So I wanted to sort of just share with you Harvard's 10 steps for coping with a chronic condition. And so this is just in general kind of a guideline for how people can kind of take control of their health. And that does tie into to palliative care. So one of the things that we wanted to talk about in this talk tonight was how palliative care can help people cope. And when I read this, I thought that this is kind of exactly what palliative care does. So, you know, Harvard recommends that a person get a prescription for information. So in other words, you know, try to get as much information about your situation as possible, because we know that with anything, knowledge is power. They recommend that you make your doctor a partner in your care. And in this case, with palliative care services, It's a very individualized approach, and a lot of one-on-one, a lot of time spent face-to-face with your team, and we really are partners in your care. They recommend you build a team. Typically, palliative care teams are multidisciplinary. They want you to coordinate your care. They want you to make a healthy investment in yourself. And I think a palliative care is a lot of that for patients, just beyond just symptom management, because they're, not only are we managing physical symptoms, but we're talking about, your home life and your mental health, and your advanced directives and what you want your life to look like. So we're kind of setting goals for patients, and allowing people to make that investment in themselves. They recommend you make it a family affair, and that you're really talking with your family members about your health situation and what your goals are. Manage your meds, care for your mental health, reach out. So ask for help if you feel like you need it. And that's a big thing that we try to do in palliative care. What can we do to help you at home? How can we make your life better? And one of the big things that we do is planning for end of life decisions. So again, this is kind of a thing of like setting a goal for yourself, being as equipped as you can with as much knowledge as possible, and taking responsibility for your own healthcare and not leaving it all up to us. So palliative care can happen in a variety of settings. So it can be done in the inpatient setting. So generally each hospital system has their own palliative care team, and it can happen on an outpatient basis. So like I said, here at OHC, we have something called the supportive care program, which is our version of palliative care. So we see patients both in our office, but also on Zoom calls like this. We do quite a bit of telehealth. And then there are in-home palliative teams who actually come to your house and do everything there. So who is on your palliative care team? So generally it's headed up by a physician. You will also see nurse practitioners, you'll see nurses, hopefully we'll see a social worker, chaplain, nutrition services. We're very lucky here at OHC that we partner with the Mercy Hospital's chaplain group to provide spiritual services for patients, and that's something that we've been grateful for. I wanted to talk a little bit about kind of what happens when we do a palliative care consult on a patient, just to kind of tell you what we are looking for and the type of information that we are trying to gain. So what I like to kind of tell patients is that I'm on a fact-finding mission. I'm trying to get to know you in a way that we don't know you in the office. I'm trying to find out what your home life looks like, and really just trying to find out as much information about you as possible so that I can help to care for you as you navigate your illness. And again, in my case, it's cancer. So when someone is referred to me for a palliative care consult, I tend to like to follow up with their attending physician to find out, why they referred the patient to me, and to ask them if there's something in particular that they want us to focus on. So sometimes patients come because they have a particular symptom that they're struggling with, such as pain or sleeping. But sometimes it is just, they want us to talk to patients about advanced directives and end-of-life decision-making. And sometimes we're not doing anything at all other than just sort of introducing ourselves to patients. There are occasions where people don't really have a lot of needs up front, but we anticipate that as they go through their illness, they may need us in the future. So a couple of different things. So the elements of a palliative care consult. So again, I'm always sort of giving people an introduction to palliative care and why I'm there sitting in front of them. We take a history of their present illness. So I want to know about what has happened on their cancer journey and kind of what life was like before they were diagnosed. What kind of health problems did they struggle with? That type of thing. We do a complete review of systems. So this is when, just like in the doctor's office, we're talking about what kind of actual symptoms they're having. Again, looking at that past medical history, what were you dealing with before you were diagnosed with your cancer? And a lot of that stuff I take out of the chart prior to seeing the patient. But, a lot of times if it's a symptom management thing, we're going to talk a lot about what that has looked like for the patient. But really, what I love to kind of dig into with folks is their social history. Again, what does your home life look like? We talk about advanced care planning. So does a person have advanced directives in place? And we'll get into that a little bit deeper here in a few more slides. We talk about spirituality because that's important in some people's lives. We then do a physical exam. So we want to just, give everybody a checkout here, just like this little doggy is getting his exam. And then we make our kind of impression in our plan. So we sort of come up with the problems that we're dealing with and then what we're going to look, to do about them moving forward. And it's important to know that we might not get to everything in that first visit. And I've certainly had situations where where I talk to someone about just fatigue for 30 or 40 minutes. And there isn't a lot of time to talk about other things. Typically for us, when we see a palliative care consult, our visits are usually over about 60 minutes or so. But, the more time, the better for these. And when I went through my palliative care training, their minimum consult was 90 minutes and sometimes 2 hours or more. So, unfortunately, we're a little bit limited by that when we're in the doctor's office. So when we talk about, and I decided that I kind of wanted to just focus on some of these things as opposed to really getting into the weeds on every single thing. But when we talk about a review of symptoms, rather, these 7 things here are the typical things that we're focusing on with palliative care. So pain is a huge one. We do a lot of pain management for patients. We focus on fatigue being the #1 complaint of cancer patients, both on treatment and cancer survivors. We talk about sleep habits. We talk about anxiety and depression, which, as you may imagine, is a huge issue for our patients. We talk about their bowel habits, primarily constipation being something that people struggle with. We talk about nutrition. And then we talk, of course, about nausea and vomiting. So those are the kind of the big 7 of palliative care. Here's the stuff I really like. So I like this social history. And from a provider standpoint, we as doctors and nurse practitioners and nurses are really accustomed to asking people about things like smoking. Do you smoke? Do you drink? Are you married? But they're, and I think patients are used to being asked those questions. But people aren't really used to going, taking that deep dive into what their life looks like outside of the doctor's office. And what I really love about this social history piece is that this is the area where I feel like we really start to build trust. We really get to know the patient and to start to frame a discussion regarding goals of care. So this is where I kind of want to know everything about you. I want to know your story. I want to know, how did you meet your spouse? What do you do for a living? Where did you go to school? Where did you grow up? We ask about their hobbies. We ask about their living situation. One of the things that I ask people is, do you have steps to get into your house? What floor is your bedroom on? Because as you might imagine, those are things that are can be a challenge for people as they sort of go through a chronic illness. Very recently, I had a patient who I saw with lung cancer, and he lived in a 3rd floor apartment with no elevator in his building. And so he was finding it very difficult to navigate 3 flights of steps with an oxygen tank and everything else that he was going through. So there's a lot of rationale behind why we're asking some of these questions. I want to know if people have pets in their home. Just this weekend, a patient of mine fell. And she got tripped up by her little dog. And unfortunately, she's got a broken back now because she tripped over her dog. And that is one of the very common reasons why my patients fall, is they get tripped up between a little dog or cat. So that's one of the things that I'm asking about when we're talking about what your home life looks like. We're also talking about safety stuff. Do you have guns in the home? Are there things in your home that would make you feel unsafe? Do you have a history of drug or alcohol abuse? And so we really kind of want to take a big deep dive here into what people's lives look like. One of my favorite questions to ask people is, tell me about a good day in your life. And it doesn't have to be current. It can be something that happened to a person 3 years ago. And I want to know, like, now, what does a good day look like for you? Because I want to see what people are wanting to do with their time. We recently had a gal tell us that she just absolutely lived to knit, and she did not want to take chemotherapy that might cause her fingers to be numb and tingly, because she did not want to take the chance that she would not be able to knit anymore. And so, once again, kind of knowing a little bit more about her decision making helped us to create a plan for her that kind of aligned with her goals. So tell me about a good day, and what's a good day look like for you? And kind of a little bit of a broader question is, what makes your life worth living? And again, I mean, these are all good questions for any of us to ask, ourselves, and things to think about. One of the things that feels sometimes a little bit intrusive to patients is when we start talking about financial matters. But it's really important. It's a very difficult but necessary conversation. Financial resources are very difficult to come by. We are very lucky here at OHC that we have financial navigators that work with our patients to help them sort of navigate some of these things. And it's a really important conversation, because about 31% of their patients will lose most of their life savings with illness. And that, to me, is just unbelievable. What is also really interesting is that family caregivers provide about 80% or more of the elderly care in the United States. And because of this, about 20% of family members are forced to quit work to become a caregiver. So there can be a tremendous financial burden associated with having a critical illness, or taking care of a loved one that is sick. So the financial piece of this sometimes feels a little bit, like I said, intrusive to people, but we really are trying to figure out, is there a way that we can kind of help people through this? So like I mentioned previously, one of the really big pieces of what we are oftentimes called in to chat with patients about, and certainly on the inpatient setting, is advanced care planning. So I really kind of want to dig into this a little bit, because I find that people will tell me that they know what it is, but really when it kind of comes down to it, it's a little bit confusing, and folks oftentimes have questions. So advanced care planning, involves basically learning about the decisions that might need to be made in the event that a person cannot speak for themselves. We want to consider those decisions ahead of time, and then communicate those decisions to your family and your healthcare providers. So what does that mean in layman's terms, and short and sweet? Well, what I say to patients is, if you get killed in a car accident, or if you get into a car accident today, and and you are knocked unconscious and can't speak for yourself, what do you want us to do for you? And then does your family know what that choice is? And that's the way that I always present it to patients. I don't even think about it in relationship to their cancer, but it certainly is applicable in that setting as well. So there are two main elements to advanced directives and advanced care planning. There is a healthcare power of attorney, and there is a living will. And if if you're in the hospital and palliative care has not been consulted to be involved in your care, this would also often be something that would fall upon the hospital chaplain to come and talk to you about. So that's something that they do very well. So first is your healthcare power of attorney, and this probably is pretty straightforward, but this is a person that that you name to make decisions in the event that you can't speak for yourself. This is a legal document, and it definitely needs to be witnessed and notarized if possible. This should be someone that you trust and someone who is able to advocate on your behalf. Obviously, this person should know what you would want to do in the event that you can't speak for yourself. What's really important to know about advance directives, and both with living wills and with healthcare power of attorneys, is that these are living documents, and so they can change. Because as people's life situations change, you might have a person who is now divorced and doesn't want their ex-spouse as their healthcare power of attorney. So these documents can be fluid and can be changed. But if we are going to change them, we still need to go through the sort of process of having it done on the legal document with a witness and a notary if possible. So what does your healthcare power of attorney need to know? So first is what medical treatments do you want to receive or to refuse? So a big one is do you want to be intubated, or that's just kind of a general umbrella term. But what do you want to do in the event that you're in the hospital and you can't speak for yourself? Would you want to be on a feeding tube, or would you want an IV that would give you artificial nutrition and hydration? Do you want CPR? That's a big one. Do you want mechanical ventilation? So in other words, do you want the tube down your throat and the machine breathing for you? If you were to develop a serious infection, would you want antibiotics? The next question is, would you want these treatments on a limited time trial basis? So I'll tell you that, I was the healthcare power of attorney for my grandfather, and he suffered a surgical complication, and we found ourselves in a situation where we had to make some of these decisions. And we decided that we would allow him to have 2 or 3 days of all of these above types of things here. And then if things weren't really making a change for the better, that we would stop all of that. So does your healthcare power of attorney know if do you want to be on a ventilator for months and months and months? These are things that a person really needs to start thinking about. And the next thing is, what changes in your situation would make you want to continue or stop treatment? So would there be something in particular that would make you say, you know what, stop everything, we're gonna not do this stuff anymore? So these are all things that I ask people to think about when they're thinking about the next steps here, which is making living will. But if you're thinking about these things and you have strong thoughts on them, your healthcare power of attorney definitely needs to know this. The other thing I want to kind of back up and say here is that your healthcare power of attorney is different from your power of attorney who handles like your financial stuff and your will, or selling your house and things like that. This is solely, it can be completely different people. So again, as a nurse practitioner, I was the healthcare power of attorney for my grandfather, but I am not the person who is handling his power of attorney in regards to his estate. So those can be different people. So a living will is something that a person can fill out if you have thought about those questions that I just brought up, and put some things on paper. So it's a written document that helps you tell us how you want to be treated if you are either dying or unconscious and cannot make your own decisions about emergency treatment. In a living will, you can say what procedures you may or may not want, and under the conditions to which of those choices apply. You can also make designations for organ donation or leaving your body as a gift, which are a couple of things that I've helped patients do through this advanced care planning. Within the DNR, within the living will, a person can opt to have a DNR, which is a do not resuscitate. We have forms for people that choose to have a DNR, even if they don't have a living will. So, there is a separate CPR form that is recognized in the state of Ohio. And so if people only really care about this particular thing, they can just fill that form out. But it is embedded within the living will, and it is something that you can make choices about if you decide to do the full document. So a DNR tells medical staff that you don't want them to try to return your heart to a normal rhythm if it stops. So essentially, you don't want chest compressions or other life support measures. And I think one of the misconceptions about this is that when people choose a DNR, they think that we're just going to stand by and kind of watch them die. And that sounds very scary to people. And in fact, that's not the case. There is what we call a DNR CC, the CC standing for comfort care. And essentially that is anything that can be done to soothe you during that process and to relieve any suffering will be done as long as it stays within the line of your wishes. So in this situation, comfort care includes managing shortness of breath. So, your heart might not be beating, but we will put oxygen on you so that you aren't necessarily feeling that. We're going to limit medical testing. So we aren't going to throw you in a CAT scanner or an MRI during this type of event to try to get more information about what's going on. We're going to provide spiritual and emotional counseling. So, to your family and to the people around you if possible. We'll give you medicine for pain. So sometimes if people will receive morphine, or they'll get medicine for anxiety or nausea or constipation. So comfort care is all of that to relieve those symptoms. We also give hydration as part of comfort care. And essentially, we're going to take care of people when their body is failing them, with the exception of pounding on the chest, to do chest compressions. So I put this picture up here, and you might recognize some of these folks. There's George Clooney there to the left, who is my favorite doctor. Most hospitals and other healthcare facilities will start CPR on a patient unless there are clear medical orders not to do so. And this is really important, especially if you are at home. Because in the home, emergency personnel will start CPR unless there is an out of the hospital DNR form signed by the physician. And I'll explain that in a second. If you have a DNR form, I always recommend that folks keep it on their fridge, because EMS is trained to look there. I was a paramedic a million years ago before I was even a nurse, and we were always trained to look at the refrigerator for medical information like these DNR forms. I brought up the idea of a hospital DNR form. Again, a DNR is another living document, and people very frequently change their mind about DNR. And a lot of it is very situational for people. And so sometimes what happens is a person signs a DNR form when they are critically ill in the hospital. But if that happens, it's important for people to know that that particular do not resuscitate order is only usually good for that hospitalization. So and you kind of start over again the next time you're hospitalized. And that's why we're always asking you, do you have a DNR? Do you have advanced directives? Because those orders can change. So if a person is kind of walking around with a general thought that they want to be a DNR, you need to have that official paperwork filled out. At home, you need to have that sort of out of the hospital document filled out. So that's very important. So here's what these three really should have told us, okay? So here's some facts about CPR. So 77% of people on television who receive CPR survive. And 97% of those survivors have no disability following the event. And when we talk to people about CPR, the studies show that people believe that CPR works about 60 to 85% of the time, when in fact, it's only successful in about 15% of the time in the normal population. 15%. That's not a lot, right? So 15 out of every 100 people who receive CPR are going to sort of come out of that event on the other side. That's not very many. 44% of those survivors will have some sort of functional decline following the event, okay? And what that means is that, you know, there could be some brain damage as your brain is deprived of oxygen during that time. We may break your ribs. The odds are we probably are going to break your ribs, and you then may develop some pneumonia as a result of that. So there can be some very long-term consequences to receiving CPR, and it is very, very different than what the general public understands based on things that they've seen in television and in movies. So unfortunately, in the situation, in the patients that I care for, so you know, many of my patients have advanced chronic illness in regards to their cancer. CPR is only successful in less than 5% of patients. So these can be very, very traumatic, life-changing events for patients if they survive it. So we want to make sure that when we're having these conversations from a palliative care standpoint, that again, we're giving people the information so that they can make a educated decision and kind of make the best decision for themselves. So I say all of that stuff, and it's, you know, again, hearing some of those facts and statistics is a real bummer, and it's hard to talk about. But one of the things that I learned in my palliative care training that kind of stuck with me is that it was the saying of a good day tomorrow starts with a good talk today. And that really applies to a lot of things in our lives. But when we think about our health and illness, you know, if you became seriously ill, you know, would the people who matter the most to you, would they know what matters to you? And so I always advocate that you share the kind of care that's right for you, and what your good days look like. Remember, we talked earlier about what a good day is for you. And so we want to talk about what a good day looks like, you know, no matter what happens tomorrow, because again, if we are prepared, you know, we offer treatment that lines up with your goals and in general, makes things better. So palliative care and advanced care planning is really patient-centered care. So, you know, again, we're providing care that is respectful of and responsive to a person's preferences, their needs and their values, and ensuring that the person's values guide all clinical decision-making. So, you know, I tell my patients, you know, you are the captain of this ship. I'm just helping you push the boat. And I'm a lot better pusher if I know what you want and I know where we're headed with this. So I encourage everyone to become the captain of their own ship. When we think about goals of care, goals allow for a very individualized care plan. that is centered around the patient and their family. It allows for informed decision making. So again, we're making decisions not based off of emotions, but making them based off of information and what looks best for the patient and their family. And again, goal setting, it's like those questions before about questions to talk to your healthcare power of attorney about. When you start thinking about, what really matters, that introspection really kind of comes through there when we talk about goal setting, because it forces a person and their family to kind of think about, well, what would I want? What means the most to me? What matters most? So that's kind of why goal setting is so important. And when we do set goals, this leads to less aggressive care. It leads to less costly care. It leads to higher quality care, and it leads to higher patient and family satisfaction. So I'll give you a common scenario of something that I have seen happen, more than once. We have patients who have, DNR orders, or patients who have hospice in place, and their family member, so the patient has some sort of event that is very scary, and the patient's family member doesn't know what to do, and so calls 911. And when the patient in a huge rush or is frantic, can't produce the appropriate documents. Sometimes patients get CPR when the patient doesn't really want that. They will absolutely get taken to the emergency room. And here we have patients who have told us that they want to die in their home, and instead they die in the emergency room, away from their family members and not in line with what they are hoping for. So again, this goal setting and this planning and putting everybody on the same page allows the patients to have their wishes met, and we get less aggressive care, which is generally for many people in line with what they want. So on to some of the other things, a little bit of a lighter topic, maybe, is the spirituality. So one of the reasons that we talk about that is because, as you might imagine, that is a very important aspect of many people's lives. So we do something that we call a spirituality FICA score. So FICA standing for faith. So what is your faith? We always like to ask people, how important is that in your life? Is there a community that you belong to associated with that? And are there any needs that need to be addressed? I have found some very interesting information about people when I ask these questions. And many patients, when they face a chronic illness, kind of go through an existential crisis. And it can really challenge the core ideas of their self and their relationship with God. People oftentimes ask themselves, why did God let this happen to me? Or my family member. People can feel abandoned. Again, they're questioning their faith. And sometimes people have a real loss of hope and meaning. And then we have also had folks who really feel that very urgent need to be forgiven. So there's a lot that can happen in this realm. And so, many of our patients are blessed to have a community through their church that is very supportive. But there are some people out there that are struggling. And so we, as I mentioned previously, are really lucky to partner with the Mercy outpatient chaplain department. Or the chaplain group. So a lot of people don't know that they have an outpatient program. And what they offer patients is really an ear, and part of their outpatient service is that they do a lot of things via the phone. So they understand that people, have difficulty coming to the office and whatnot. So they do a lot of just touch point via phone or telehealth, if that's what people want. And with our program, with our supportive care program at OHC, they have offered us the option of being able to see patients at the Cancer Support Community Office at Eastgate. They've told us, that they will come to us if possible in some of our offices to see patients if that is something that people need. So I've had a couple of people take me up on that program and have felt very supported through that. And in one of my patients, as an example, it was just a lot of phone calls, and she felt like she had an extra ear. And so this is a really wonderful, wonderful service that Mercy offers. But in general, we always kind of want to see where people are regarding their spirituality. So what do we do with all of this information once we have it? So we create a plan that is tailored to each person's specific needs. We manage symptoms. And, I didn't want to get too much into that. We talked about that review of symptoms earlier with the pain and the fatigue. I could talk for hours about methods and ways that we manage particular symptoms, but it's difficult to sort of talk about in a setting like this because it is very specific to the person. And so we have a variety of different interventions that we utilize to manage a person's symptoms. So we refer to specialists as appropriate. So sometimes I find that a person needs to see their pulmonologist because I can't really help their breathing, or maybe I think part of the reason they're not sleeping well is because they've got sleep apnea and they need a sleep study. So those are some of the things that we help to do. And then, one of the big things that we do is we refer to our local community groups for additional support. So cancer support community being one of the biggest places that I refer patients to. But depending upon which type of cancer a person has, I will refer to specific organizations that are individual to that person. And then what we communicate all of our findings with the patient's primary medical team. And this is a huge one because oftentimes I'll come back with information that, the primary care team just had no idea about. And very often we are able to shed light on some of the rationale for why people are making the decisions that they're making. And so in other words, if they know that a patient has a disabled child at home, that helps them to better create a treatment plan that kind of lines up with their ability to, not be in a doctor's office and to be home and taking care of their disabled child. So, and many times these types of little details would not necessarily come out in the doctor's visit, as we are so kind of laser focused on what we're doing, which is treating the cancer. So my last slide for you here is where can you find palliative care? So, this is all here in Cincinnati. Hospice of Cincinnati has a wonderful outpatient palliative care program. They're called actually Palliacare. Crossroads Hospice and Palliative Care Services. Again, we here at OHC provide palliative care, although we provide that service only for our patients. We don't see any outside of OHC patients for palliative services. There's CareBridge, and then Cincinnati Children's Hospital has a wonderful program for children. And again, this is just some of the places that you can find palliative care in Cincinnati. So I want to thank again Cancer Support Community for having me here today to talk about palliative care, and I'll take questions if there are any. Thank you very much.